Hi everyone, my name's Natalie. I think I know most of you here, and I'll be presenting along with my colleague Chris Lee. We're doing Journal Club today. We're both looking at Cochrane reviews, and the article that I'll be discussing with you today is Probiotics for Treating Acute Infectious Diarrhea, and it was published in the Cochrane database in 2010. So the problem of diarrhea, acute infectious diarrhea, it's a major disease burden, especially in developing countries, especially in the pediatric population. We do see a lot of it here, but its outcomes are more significant elsewhere in the world. It can be caused by many different viruses, bacteria, and parasites. And because most episodes are self-limiting, often we're not testing to identify the specific agent causing the diarrhea. The main health risks associated with diarrhea, number one probably being dehydration. And so our major treatment usually focuses around either PO or IV fluids. But unfortunately, while these help with the dehydration aspect of things, they don't necessarily reduce the stool volume or shorten the duration of the infectious diarrhea. So a few notes about probiotics. They're considered to be microbial cell preparations or components of cells that have a beneficial effect for the host. It's been sort of noted that even closely related probiotic strains have slightly different clinical effects. So some authors have stated that we can't necessarily attribute specific effects of one strain to all probiotics or even closely related strains. The thought is that they act against enteric pathogens mostly by competition, so competing for nutrients, and binding sites within the gut. They'll make the gut contents more acidic, making it a more difficult living environment for pathogenic organisms, and they can sort of generally increase our immune responses. Through numerous studies that have been done, they've not been associated with any adverse effects in well patients. So potentially we can get some benefit from this with very little risk of any adverse event. So this study objective was to assess the effects of probiotics in proven or presumed acute infectious diarrhea. And the outcomes that they looked at in this study were the duration of diarrhea, diarrhea lasting greater than 4 days, stool frequency on day 2 post-intervention. Secondary outcomes that they looked at included diarrhea lasting more than 3 days and stool frequency on day 3. So in this meta-analysis, the criteria for being considered, the studies had to be either randomized or quasi-randomized controlled trials, looking at the effect of either a single probiotic or multiple probiotics on acute infectious diarrhea. And for the purposes of this study, they defined acute as less than 14 days. Participants included adults and children with acute diarrhea, and in some cases it was proven infectious, and others it was just presumed. Participants were excluded if the diarrhea was thought to come from another known cause, so if it was post-antibiotic treatment or related to something else. So as far as interventions goes for these studies that were being included, they had to identify a specific probiotic, and they didn't include studies that would have used sort of a yogurt or other fermented foods where they couldn't actually identify the organism being used. And there had to be a control, so either a placebo or no probiotic. And on this basis, a number of studies were excluded because often they would do probiotic versus antibiotic. And then other than the intervention, the control arms had to be treated identically in relation to the treatment group. So the authors searched all relevant studies in all languages, regardless of the publication status, and they performed their search on July 1st. And they looked at the Cochrane Infectious Disease Groups Register, their Controlled Trials Register, Medline, and Embase. They also contacted organizations and individuals working in the field to see if they could help identify some additional published trials or if there was unpublished data available. So their initial search found 120 potentially relevant studies, and of those, 57 were excluded. This included sort of preliminary or duplicated reports, A lot of them didn't have a non-probiotic group and no control. And as mentioned previously, some did antibiotic versus probiotic. A number were not randomized controlled trials, and some were looking more at the prevention of diarrhea versus treating an acute episode. So overall, 63 studies were included, and that was a total of 8,014 participants. So 6,480 of these were infants and children under 18, and 352 were adults. Sort of one of the major issues with this study is they sort of included everybody. So 44 studies were included inpatients, 7 included outpatients with diarrhea, 7 included both, and in 5 studies it was unclear. Another issue they came across was a lot of these studies had variable criteria for acute diarrhea. So some used description of stool, some stated there had to be a minimum number of stools per day, some said twice normal frequency. For infants, often it was sort of up to the mother's discretion whether it was diarrhea for their child. Bloody diarrhea was variably included, so 10 specifically included it, 32 specifically excluded people with bloody diarrhea, and 21 studies didn't specify either way. Some included or excluded children with rotavirus. Some included malnourished children specifically, while some excluded. And some allowed previous antibiotic treatment, where others didn't. And then again, in some studies, it was unclear. So incorporating a whole lot of different factors into the study. Another thing that had to be considered was patients coming from developed and developing countries. So there's a list there of all the countries that were included, or patients from these countries included in these trials. So as you can see, we have very developed countries, France and Italy, but there's also some developing countries in there that I think a lot of the patients at baseline have a much different health status than patients that we would typically see in our emerge department. And interestingly, none of the studies came from North America out of the 63. So looking at the interventions in the 63 studies, they were highly variable again. 46 looked at single probiotics and 17 looked at multiple. They used different organisms. Lactobacillus casei was the most common in 13 studies. S. boulardii was the next most common with 10. Enterococcus, lactic acid bacteria was in 5, and then all the rest I didn't list because they were in 3 or fewer studies. There was variability whether they used live or killed probiotic preparations, and it wasn't mentioned in some. And then dosages and treatment regimes, the duration of treatment were all variable. So the risk of bias assessment, there were 2 blinded reviewers that independently assessed each study for methodological quality using the following 4 parameters. So the first was generation of allocation sequence. It was considered adequate if the study authors stated that they used a method that resulted in an unpredictable sequence, so a random number table or list or a computer-generated random numbers. It was stated to be unclear if they said that they randomized it but didn't explain how. And then it was considered inadequate where the allocation could be related to the patient's prognosis. So of the 63 studies, only 36% were deemed to be adequate with respect to the generation of allocation sequence. As far as allocation concealment, again, the authors outlaid it sort of in a similar form. If it was stated very clearly how it was done, it was adequate. If they said that they did it but didn't explain how, it would be unclear, etc. Only 24% were considered to be adequate. With respect to blinding, only 35% or 35 out of the 63 studies were adequate, and 71% of the studies were adequate with respect to loss to follow-up. So unfortunately in this, as you can see, a lot of these studies weren't specifically very high quality in their methodology. So a summary of the results of the 63 studies, they did use a random effects approach. And overall, they found that probiotics reduced the mean duration of diarrhea by about 24.76 hours, or about a day. And they got that information from 33 trials and about 4,500 patients. As you can see, though, and I'll come back to this in a moment, very heterogeneous data with an I-squared of 97%. With respect to their other primary outcomes, the probiotics reduced the risk of diarrhea lasting 4 more days by 59%. Again, an I-squared that's pretty high. And reduced stool frequency on day 2 by about a stool. And they were able to include the information from 20 trials in that data. So looking at the heterogeneity, it's describing the percentage of variability in the effect that's actually due to true differences rather than chance alone. And an I-squared over 75%, let alone sort of the 97% that we see there, is a very high level, and some would argue that this data shouldn't even be pooled. However, obviously it was. So the authors tried to do some subgroup analysis to see if that could account for some of the heterogeneity that they found. They looked at probiotic strain, dose, single versus combination therapy. They looked at adults versus children, the specific diarrheal pathogens when known, the severity of the diarrhea, and the mortality stratum. And the heterogeneity persisted, so it couldn't really be explained by any of these factors that they looked at. So what can we take from this? Well, despite this very high level of heterogeneity, it still was able to demonstrate that probiotics do have a significant effect. So we can say that the effect is significant. What we can't really tell is the accurate size of that effect. So we can say and rely that it will decrease the mean duration of diarrhea, the number of stools on day 2, and the risk of diarrhea persisting beyond 4 or more days in the setting of acute infectious diarrhea. So what are the clinical implications, and how do we take this to our practice in the eMERGE department? We can say that probiotics appear to be helpful, but this review wasn't really able to give us specific evidence for specific population groups. So I would say if we're seeing somebody in eMERGE that is coming in with infectious diarrhea, from this study, I think we could consider offering patients probiotics. Now, the general sort of accepted dose for those that might be interested in prescribing is sort of 5 to 10 billion colony-forming units a day in children and 10 to 20 billion per day in adults. And the duration of treatment is sort of highly variable. So you could say a week or 2 weeks until the end of the diarrhea. Again, no adverse effects known. I called one of the pharmacies in town just to ask how often that they're seeing this being prescribed. They say that it's not covered, probiotics aren't covered by the Ontario drug plans, and very few private plans actually cover probiotics. And for a typical dose or a bottle, they said the cost is somewhere between $15 and $25, and that might be for a bottle sort of 100 capsules, and people could be taking sort of up to 3 a day. So that might be a month's supply. So I think we could consider offering this to patients, saying that, you know, there is some evidence that this may be helpful and it may shorten the duration of your diarrhea. We're not really sure of the effect. And that's kind of that. So any questions or comments? Yes.
I had a question for you. You know, sometimes I just tell people to buy some Activia and eat a bunch of that, but I don't know how many colony-forming units that are in. Like, should you eat 6 a day, or do you have any idea?
I have no idea what exactly is in Activia, and in this study, they specifically said that they excluded yogurt, so I don't know if that would fall.
What did you say? The study specifically said?
That they excluded yogurts, yeah.
Because I think it makes, this has more evidence than a lot of the stuff we do, but you know, it does. It has most of this. It has more evidence than most of the stuff you prescribe, John.
This is garbage. This is
most of what we do is
No,
most of what we do is
we get
garbage.
penicillin for strep throat. We know it'll kill strep. It may not shorten the course of the illness, but we know that.
Oh, there's not much evidence. There's not much evidence.
All right,
for
pick a bad
that.
one. I pick a bad one.
I think you may have picked a bad one.
Yeah.
It's okay to pick bad examples.
Yeah.
Because it does point to Evan's thing that a lot of the stuff we do is not always deeply rooted in any type of evidence. Like, we all know that.
The best thing about this is there's not much harm. It gives us something to do because we always have the feeling that we should have some therapeutic intervention. It gives the patient something to do. There's not much harm and there's some rationale behind it. So I'm going to keep up with the Activia.
I don't know. I really don't know how much there is. Do you know, Naveen?
Activia?
Yeah.
It keeps me moving, so.
I don't think it's anywhere close to the 5 billion though.
There is a study out there, I learned this while on my internal medicine rotation from one of the gerontologists, and there was a study that was a prevention thing, so they gave elderly patients 1 ounce of a probiotic yogurt with the first dose of their antibiotic. They actually gave it in the hospital, and it significantly decreased their rates of diarrhea related to the antibiotic. Yeah. And it was one ounce dose, and that was it. They didn't have to continue with it. It was just 1 dose with the first dose of their antibiotic. It was Dr. Breimer who reviewed the article with us, so I'm sure he would have it if he'd known it.
So Activia it's Bifidus regularis, and their website is saying there's billions, each serving contains billions of natural Bifidus regularis cultures, but they're not really specifying how many billion. It's just billion.
Sorry. Are they live?
Yeah.
This is just their commercial website. It doesn't really specify that. It just says what the probiotic is, and it has billions, so I don't really know.
Whether they're live when you eat them, but I think on the label it actually says live probiotic.
Is it?
I've got 5 to 10 billion, but that's also the same type of source.
Interesting. So that's similar to the therapeutic dose in this.
Yeah.
And that's per serving?
This is in,
Did they say whether or not for the capsules they were refrigerated or not refrigerated?
To be honest, I'm not sure. Everything was variable. And I didn't specifically go through the 63 studies to look at whether they were refrigerated or not, so I couldn't tell you. But some were live and some were not. So whether it was, they didn't really discriminate in including only live preparations, so. Yeah?
I just wanted to make a comment and just pick your brain as to what you thought about this. Something that doesn't really make sense, and I was wondering if you could think about why you got this result, is that when you look at your I-squared statistic, it definitely shows a lot of heterogeneity. Why do you think the estimate of your precision was, or the precision of the estimate was so good with such a big heterogeneity?
I think what that's telling us is that despite the heterogeneity, there did seem like most, if not almost all studies, did find some sort of effect. So across the board, there seems to be some sort of beneficial effect. I think the problem is we can't say how much. But I am not a statistics whiz, so maybe Shelley could help me with that.
No, that's no, that's exactly right, Natalie. You're completely right. Did you have a different thought, Naveen? Or?
Oh, no, I thought so too. See, the thing with the I-squared statistic is that when it was invented, like what was it, like 10 years ago or something? Yeah, the guys who made it up, they sort of made those numbers up, I think. Like there wasn't a lot of evidence behind why they chose 75%. So if you have a lot of studies, like 63, I think is a lot of studies, that I-squared statistic is too good at picking up heterogeneity. So,
but the studies are also so completely different.
Yeah.
Right? So that's why your I-squared statistic is so high.
Yeah.
The I-squared statistic will tell you what's the difference due to chance alone. So if you have anything greater than 50%, you have to be quite concerned about pooling that data. When you have an I-squared of 97%, that, in my opinion, that data should never have been pooled.
Yeah.
They're just so completely different. I mean, you have some of the studies that Natalie looked at they specifically looked at impoverished children who were malnourished in the middle of Africa, and I don't think that you can rationally and logically pool that data with inpatient adult populations in Italy. Like, to me, they're just so inherently different.
Right.
So I think that's why they had a difficult time trying to describe the differences when they started looking into their a priori sensitivity analysis to describe the heterogeneity. But they just shouldn't have been pulled to begin with.
Yeah. If you look at the effect that you're saying may exist, one would have to question whether or not that's clinically significant. I mean, we're talking about perhaps, I think it was 0.8 fewer stools per day.
On day 2, so yeah, 1 fewer stool.
24 hours less stooling.
But the duration.
And with no definition knowing what they define as being diarrhea in the first place. I mean, we all know that we ask patients, have you had diarrhea? And they say yes. And then the next question is, how many times? And they say once. So to patients, diarrhea is a watery or a loose stool. To us, it's multiple stools, usually watery. But in fact, I haven't looked up lately the exact definition, but I think it's multiple watery stools.
And each study had their own different
Right, well,
definitions.
that's the point I'm making. So, and if somebody's the people who are really having severe diarrhea and they're having 15 or 20 stools a day and you drop it by 1, is that significant? If you're having 2 a day and you drop it to 1, well, that's definitely significant.
Yeah.
But
And
if you're
that's
having 2
safer.
a day, it's kind of like, who cares?
Because it's not that bad. But the duration, reducing the duration by potentially a day, and again,
Again, this is like the Tamiflu stuff, where they said that if you gave Tamiflu early on, in the first, I can't remember, it was 24 or 72 hours of symptoms, that you could reduce the duration of the flu-like symptoms by 1 day. And most of us said, so what?
yeah.
I don't know, though. I think it's a patient important outcome. So if you're a mom or a dad who has to stay at home for an extra day, take that time off work, or if you're a child who has to miss an extra day of school or anything, I think a day, to me, sort of makes sense. Like, I don't know, I'm sure you can argue it either way, but I think a day is pretty reasonable. And what's the downside of taking it? There's not a lot of adverse events. Certainly, I don't think there was any adverse events reported.
No, I think out of the 8,000 patients, there was one sort of query hypersensitivity reaction, and that was it.
Just one final parting shot, we could all take cold FX as well.